Good afternoon, good morning, good evening, and a warm welcome to everyone joining us from different regions around the world. My name is Dr. Chinwe Ochu. I'm the Vice Chair of the International Association of National Public Health Institutes Committee for Pandemic Preparedness, Response and Recovery, and the Director of Planning, Research and Statistics at the Nigeria Center for Disease Control and Prevention. I have the honor of co-facilitating today's webinar with Dr. Majid Al-Gunaid of the Eastern Mediterranean Public Health Network, EMPHNET. But before I invite Dr. Gunaid to introduce himself, I would like to read to us a welcome address on behalf of the chair of the IANPHI Committee for Pandemic Preparedness, Response and Recovery, Professor Menkor, who is regrettably unable to join us today because he's traveling and can't connect. He asked me to convey his apologies and to deliver this message on his behalf. On behalf of the IANPHI Pandemic Preparedness, Response and Recovery Committee and our co-host, the Eastern Mediterranean Public Health Network, it is my great pleasure to open today's webinar on cross-border preparedness, optimizing pre-pandemic and early pandemic communication and data sharing across borders. This joint initiative reflects our shared commitment to advancing regional collaboration and collective resilience in the face of future public health threats. As we know all too well, pandemics recognize no borders. The speed and effectiveness of our response depend on how well we communicate, coordinate, and share information long before a crisis gets to us. Today's session builds on the IANPHI Pandemic Preparedness, Response and Recovery Committee's ongoing efforts to strengthen the capacities of national public health institutes in preparedness, response, and recovery. The committee has prioritized fostering partnerships, promoting evidence-based learning, and generating resources that transform lessons learned into concrete action. Our collaboration with EMPHNET exemplifies this approach, which is bringing together technical expertise, regional experience, and the convening power of networks that bridge policy and practice. Together, we aim to facilitate frank dialogue on how to harmonize data systems, build cross-border trust, and develop interoperable mechanisms for timely early warning and coordinated response. We are honored today to have with us a distinguished keynote speaker, Dr. Esther Hamblian from the WHO headquarters in Geneva, and an excellent panel of experts representing diverse regional perspectives from the Robert Koch Institute, Germany, Foundation for Innovative New Diagnostics, FIND, the ECOWAS Regional Center for Surveillance and Disease Control, and the Eastern Mediterranean region. Over the next 90 minutes, I encourage all participants to engage actively, share your insights, ask questions, and reflect on what collective actions are most feasible and impactful. Our aim is not just to discuss what needs to be done, but to identify how we can all work together to do it, linking national capacities with regional solidarity and global cooperation. Once again, thank you for joining us and for your continued commitment to strengthening pandemic preparedness and response systems across borders. So now, before we begin, I would like to share a few quick housekeeping notes to ensure everyone has a smooth experience in what promises to be a very exciting session today. Our webinar, like I mentioned before, will run for 90 minutes, and that will include a Q&A presentation and a panel discussion. And we're going to have an interactive exercise which promises to be fun. We will conclude with key reflections and next steps from the facilitators. The session is being recorded, and the recordings will be posted on EMPHNET and IANPHI websites and made publicly accessible as appropriate. We encourage you to please use the Q&A box to post your questions at any time during the session, and please indicate to whom your question is directed if necessary. We will bring selected questions to the panel during the Q&A segment. Later in the program, we'll have a short scenario-based polling exercise. Please keep your devices ready and handy so that when you see the pop-up on your screen, you will be able to participate. We encourage everyone to please participate in that poll. It will help us to get more input from the diverse group of audience that we have. If you experience any technical difficulties, don't hesitate to send a private message to the tech support team in the chat box. You are welcome to share insights from today's discussion on social media using the hashtag #IANPHI, IANPHI, #EMPHNET, EMPHNET, and #Pandemic Preparedness. Finally, thank you again for joining us and contributing to this vital conversation that we're having on strengthening cross-border preparedness and data sharing. It's now my pleasure to hand over to my co-facilitator, Dr. Majid Al-Gunaid, to introduce himself, provide a brief overview of the webinar's objectives, and introduce our keynote speaker. Over to you, Dr. Gunaid. You're on mute.
Thank you very much, Dr. Chinwe, for the introduction. And on behalf of EMPHNET, I would like also to welcome all colleagues from different parts of the world, including our keynote speaker, panelists, and participants. And good morning, good afternoon, good day to all of you. And we hope that we'll have a highly interesting webinar. This is the cross-border preparedness, optimizing pre-pandemic and early pandemic communication and data sharing across borders. This is a highly sensitive and a highly important topic that we are considering it as one of the hot topics. It have been organized, and my colleague mentioned, in collaboration between EMPHNET and IANPHI Committee for Pandemic Preparedness, Response and Recovery. What we are aiming at this webinar is to examine how stronger regional collaboration can improve pandemic preparedness, building on lessons from recent health emergencies, also taking into consideration the COVID-19 pandemic. This session will highlight the importance of trust, transparency, and interoperable data systems in enabling timely cross-border communication and effective early warning. And I think this is a very important area that we'd like to highlight on it, and how can we operationalize this area. Discussion also will explore practical strategies to overcome barriers, sensitivities, and challenges facing this area, harmonizing reporting protocols, and leverage innovative technologies to support rapid detection and response. With a mix of keynote presentation, panel dialogue, and scenario-based exercises, the webinar will provide a platform for exchange of experiences and shaping concrete actions that strengthen resilience and regional coordination in the face of future public health threats. So we are looking forward for your active participation. We are looking for that your questions, your comments, and we think in this webinar we will just pave a road for next steps also for furthermore discussion and collaboration between partners. Thank you very much, and we will start with our first presentation, which is the keynote speaker. Our keynote speaker for today is Dr. Esther Hambelian. Is an epidemiologist in the World Health Organization's Health Emergency Program and is the unit head of the Public Health Intelligence Unit at WHO headquarters in Geneva. Previously, she was at the WHO Regional Office for Africa, supporting the response to outbreaks with a focus on strengthening surveillance systems for data collection, correlation, and analysis, and to better target interventions activities. Prior to that, she was based at the WHO country office in Liberia, where she led the WHO epidemiology team during the Ebola response and subsequently recovery and health system strengthening phase. She previously worked at Public Health England in the field of epidemiology services. Dr. Hambelian will lay the floor for today's conversation and talk about the critical role of regional coordination in pandemic preparedness, which will be also the layout for furthermore discussion and the participation of our panelists. So welcome all colleagues, welcome Dr. Hamilton, and the floor is yours for your keynote presentation.
Thank you very much, Dr. Majid. I just wanted to quickly check you can see my screen okay? Yep, I've got nods, brilliant. So firstly, very big thanks to you, Dr. Majid and Dr. Chinwe, as well as IANPHI and EMPHNET for the invitation to speak today. It really is an honour to be setting the scene for such an important topic as you've described. So I really look forward to this, as well as the discussions that are coming slightly later. So I'm going to talk about how critical regional and global coordination is in pandemic preparedness. Pandemics pose a global threat, we know that, but it's not just to health, it's to economy and security as well. And COVID-19 was an incredibly powerful demonstration of the devastating consequences of pandemics. But if we look at current outbreaks of Mpox, of Ebola, of cholera, this reminds us that the next pandemic is not if, but when. So first, I'm just going to take us through a very quick, very brief history of some pandemics. And this visualization on the left-hand side, I can't claim ownership for, but it outlines some of history's most deadly pandemics. From the bubonic plague in the 14th century, which is actually estimated to have killed around 50% of the global population at the time, to Spanish flu in the 1900s, which killed around 45 million people, to obviously our most recent pandemic of COVID. These all showed that the more developed humans became, with larger cities, more exotic trade routes, and increased contact with different populations of people, animals, and ecosystems, the more pandemics came to occur through history and the faster they spread. And I think this is also exemplified by the right-hand side of the screen that shows that the bubonic plague took 15 years to spread globally in the 1300s, whereas COVID-19 took a number of weeks. And as these new diseases emerge and old ones resurge, pandemic preparedness, which we're talking about today, has become a critical concern for global and regional public health bodies. So we are seeing an increase in global health threats due to the proliferation of the drivers of pandemic risk. And this can be thought about around 5 factors: social, technological, economic, environmental, and political factors. And these are known as the STEEP framework. And this is outlined in the Global Preparedness and Monitoring Board's framework. So these drivers include global mobility and misinformation, climate change, economic inequality, which have all been identified as having really significant impact on pandemic emergence and disease amplification. But these drivers aren't linked to a specific pathogen, although there are certain diseases where the drivers may have more influence over the course of the epidemic. For example, global warming and the increase in cholera we are currently seeing at the moment. But just to focus on a few of these, we know that urbanization is bringing more and more rural residents into denser neighborhoods. And in fact, since 1950, the number of people living in cities has increased so dramatically that there's an estimate that by 2050, nearly 70% of people will be living in urban areas. And with that higher population density, hosting of mass gatherings, daily commuting, etc., these really are the ideal conditions for disease spread. And with this, we also see changes in agricultural practices, with large-scale production due to the demand for more food impacting our environments. And the number of livestock overall has increased dramatically. And we saw this as an impact driver for the rapid spread of H5N1 globally last year. But we also see pandemic risk through small-scale backyard farming. Zoonotic influenza transmission, particularly in Southeast Asia, is common in communities where people keep chickens and backyard poultry. But these sporadic cases are mostly mild, but through mutation events, this could lead to an outbreak and eventual human-to-human transmission, which could lead to an epidemic. And this is why we undertake the country, the regional and the global surveillance activities and why they're so important. But all of these, we need to consider climate change, which amplifies the risk of all of these drivers. The warmer temperatures expand the range of mosquitoes, and we're currently seeing countries in non-tropical regions like Southern Europe experiencing cases of dengue and chikungunya for the first time. So global movement through travel, through trade and migration is at a record high, and this global movement is becoming a major amplifying factor of epidemics and pandemics. But this global interconnectivity requires global solutions, and regional and global coordination is really no longer optional. It really is essential for what we all do. But we already have a number of tools in our toolbox to support this regional and global coordination. And one of the most key of these, and has been around for quite a long time, and that's the international health regulations. The root of the IHR actually goes back to the mid-1800s when there was the first International Sanitary Conference in Paris. And this was held because cholera, plague and yellow fever were rapidly spreading due to an increase in global travel and trade, some of the same risk factors we're seeing now. So nations began to cooperate to standardize some of the quarantine measures. But it wasn't until around 100 years later, when the World Health Organization was established, that countries came together to develop that first set of regulations, which were called the International Sanitary Regulations. These were then updated and became the International Health Regulations in 1969. But again, the scope remained quite narrow. It was really focused on 3 diseases, on the cholera, plague, and yellow fever. And so it wasn't until after the 2003 SARS outbreak, with also the start of the HIV/AIDS pandemic in the 1980s in recent memory, really exposing serious limitations of the IHR 1969. So work began to revise the regulations, and in 2005, the WHO member states adopted the revised IHR, and some of the key innovations of these was that there was a broad definition for what they covered. We were no longer focused on those limited number of diseases, but it focused on potential public health emergencies of international concern and the need to report these internationally. And to do this, there were obligations for countries to build better surveillance and response capacities. So this next slide actually shows how many events countries report as potential public health emergencies of international concern using the decision instrument in Annex 2 of the International Health Regulations. So since 2009, nearly 5,000 events have been assessed by countries, by the member states of WHO, to have the potential to be a public health emergency of international concern. So these are public health events impacting individuals and communities on a daily basis in countries across the globe. So every year there are between 300 to 450 events reported. And the difference between a localized outbreak and a global pandemic is the preparedness activities. And these notifications under IHR are a key factor for this. If you look on the other side of the slide, you can see over the same time period since 2009 that 8 public health events have been declared as public health emergencies of international concern. And this was until recently the highest level WHO gave to show that an event poses a global health threat and requires a coordinated international response. So although we have numerous outbreaks occurring on a local level, on a national level, on a daily basis, they do not all become the fakes. but are able to be contained due to the work of countries and regional bodies for early detection and swift rapid response. The next step in improving global and regional coordination in light of the experiences we all had and all felt during the COVID-19 pandemic was that it was requested that amendments were made to the 2005 International Health Regulations. And these amendments were developed through a member state-led working group and negotiated by all 196 states parties. And the amended IHR actually came into force last month in September. Some of the key new elements of this are listed here. These include a commitment to solidarity and equity through strengthening access to relevant health products and the establishment of coordinating financial mechanisms. And regional coordination will really be essential to ensuring that these are enacted. And then one of the key IHR amendments was the inclusion of the determination and definition of a pandemic emergency. A pandemic had not previously been included in the IHR, it was the fake. But a pandemic emergency is now the next level. It is a public health emergency of international concern caused by a communicable disease and has or is at high risk of having wide geographical spread, is exceeding or it has the risk to exceed the capacities of health systems, and it is at high risk of causing substantial social and economic disruption, as well as requiring rapid, equitable, and enhanced coordinated international action with whole of government and whole of society approaches. So under the IHR, one of WHO as a global public health body has a key role in cross-border communication and supporting data sharing across borders. We work with many regional and global partners to do this and to strengthen country capacities to prevent, prepare, detect and respond to public health events. But there is a global network of 196 state parties of the IHR, 150 country offices of WHO and the 6 regional offices, as well as the many multiple regional bodies and partners with specialisms in particular areas. And this network of trained people and regional entities is really essential for our activities in supporting countries in handling these public health events and emergencies that have the potential to cross borders. So how do we alert people to the fact that a public health event is ongoing? We saw that 300 to 500 events are reported every year that they're of concern to a country and they are concerned about the potential international implications of that public health event. So all these events are assessed by technical experts and information is shared on them through a secure platform called the Event Information Site for IHR National Focal Points. So in each country, the IHR National Focal Point is able to access this information about ongoing, new and ongoing public health events. And this information is shared early and in confidence with the member states. And the information shared is, for example, information about the epidemiological update on the event, the response actions that are being taken, WHO's assessment of the risk of that event and the risk to other countries, as well as advice and recommendations that countries that are not affected should take to enhance their preparedness activities and their readiness activities. But it's not just to those who are IHR national focal points that we want to disseminate information about public health events to be able to support preparedness and readiness activities. Information is also shared to the public through a particular product called the Disease Outbreak News. And this is a product that's been ongoing now for more than 25 years. And this as well gives a summary of the known epidemiology of an event and WHO's risk assessment and advice. But we also utilize other forms to support cross-border collaboration through specific situation reports, for example, regular situation reports on the Mpox outbreak or the cholera situation. And we also have emergency dashboards or event-specific dashboards. And I think what's really important here is that access and use of social media we know is prolific and continues to be on the rise. So it's really essential that regional or global public bodies are the trusted authoritative source for information, for accurate and timely sharing on public health events. And we really hope that some of these listed here supports that. And I mentioned trust. We really have seen a decline in trust in many countries, distrust in institutions, in multilateral systems, which really impacts our collective ability as people who work in public health to tackle health emergencies and find those multilateral solutions to protect the world. However, the adoption of the pandemic agreement earlier this year really gave us hope to demonstrate that multilateralism is not over. Trust still exists. It took 3 years of negotiation for the treaty to be adopted to really make the world safer for future pandemics by encouraging better disease surveillance, sharing of vaccines and other medicines during major outbreaks. And it really sets out the principles and the approaches and tools for better international coordination across a range of areas. And I just want to show a recent example for the last section of this brief overview presentation to really focus on some of the more recent public health emergencies of international concern. So we've had 2 fakes in recent years declared as a result of Mpox, and I'm sure many of those online have been working in the response to these as well as preparedness activities. The first fake was declared in July 2022, and it was declared that it no longer met the criteria of a fake in May 2023. So the outbreak was ongoing, but it didn't fulfill the criteria that make a fake. And this outbreak really focused on clade 2 Mpox, which started in Central Africa. But key to what we're talking about is the fact that it spread to more than 100 countries, as you can see on the map on the left-hand side. And we were able to track and respond to the spread of this epidemic through the international regional collaborations and data sharing from countries. Then in 2024, a different strain of Mpox, clade 1b, was being observed to increase significantly, particularly in the Democratic Republic of Congo, and was rapidly spreading to neighbouring countries. And again, we knew of this spread through the IHR notifications being submitted from those countries who were affected. On the right-hand side of this slide, you can see data from this most recent Mpox fake. And the table really shows here that the African region has really borne the brunt of this epidemic. But again, importantly, all regions are affected. If we look at countries by transmission status in the map on the left-hand side, you can see in green countries who have reported clade 1b cases. And in yellow, countries that have reported cases linked to travel. And then in orange, these are countries with community transmission. But what I wanted to focus on a little here is the travel-related cases. And it's important to see that 20% of all those travel-related cases actually led to secondary transmission in a new country. And another key point is that we also see exportations from countries who've actually not reported cases under the IHR. And this indicates to us that there's undetected community transmission in some areas. And we can compare these travel-related cases to flight patterns. And you can see the expected importation countries based on commuter risks is on the right-hand side of the screen. And what we actually saw is on the left-hand side of the screen. And this really shows how important it is to undertake risk analysis as part of our preparedness activities. You can see that the exported cases actually did align to the commuter routes, and that gives us a clear activity to undertake as part of our preparedness activities. So from data sharing and collaboration, we can see that there was a better understanding of the transmission risk factors, which informed the global risk. It enabled us to monitor regional risk and geospatial spread, and also highlighted risk analysis based on those flight patterns. But during the MPOX fakes, international bodies such as WHO worked very closely with governments in those countries that were affected, as well as regional bodies, particularly Africa CDC for MPOX. And we worked together to understand and address the drivers of the outbreaks through a comprehensive and coordinated response under the HEPA framework, so the Health Emergency Preparedness and Response Framework. And this really emphasizes 4 key aspects: the surveillance, the collaborative intelligence and the early warning aspect, the research and equitable access to medical countermeasures, the clinical care and resilient health systems, and the community engagement and population interventions. But this HEPA system needs to be interconnected, not only vertically across the local, the national, the regional, and the global levels, but also horizontally across different disciplines, whether that's on human health, on animal health, on environmental health, or the many people that work within this sphere. So, lastly, we all know, we all work in this world, pandemics are not rare. They're not once in a century events anymore. The risk is ever present and is increasing. Pandemics are global threats, but ultimately we must remember that they begin and end in communities. And we really need to build the trust in resilient national and local and regional public health services supported by regional entities for health emergency preparedness and response systems. Because ultimately no one is safe until we're all safe, and everyone has a role to play within this. As our Director General always says, a health threat anywhere is a health threat everywhere. And I hope that was a useful introduction to this session today.
Thank you so much, Dr. Hamblin. Indeed, a health threat anywhere is a health threat everywhere. This is a very insightful presentation that sets the stage perfectly for the next session, the panel discussion. We will be talking on the critical role of regional coordination in pandemic preparedness, and we have experts that will be helping us to go through different topics. We have Professor Johanna Henfield, who is the head of the Center of International Health Protection at the Robert Koch Institute, Germany's National Public Health Institute. She is currently the acting vice president of RKI, and since 2019, the Center for International Health Protection coordinates RKI's international work. It is home to approximately 90 scientists who work collaboratively with bilateral and multilateral partners to strengthen public health systems worldwide. Johanna Henfield is also an honorary professor of global health policy at the London School of Hygiene and Tropical Medicine. Dr. Ginard will introduce the next speaker. the next panelist.
Thank you very much. I will also introduce our next speaker in this panel, Professor Muhammad Mus'af from Morocco. Dr. Muhammad, with expertise in public health, global health security, travel health, and aviation medicine, is the national coordinator of Morocco's Point of Entry program at the Ministry of Health. Chatham House Global Health Security Fellow, he has led border health responses to major outbreaks since 1996. Internationally, he contributed to revised and adopting the IHR 25, conducted more than 40 WHO IHR missions, including 13 joint external evaluation across all WHO regions, and co-authored WHO point of entry guidelines. He serves on multiple WHO technical committees, Africa CDC steering bodies, and the World Bank Pandemic Fund Technical Advisory Panel. So welcome, Dr. Muhammad, to this panel. Back to you, Chinwe, for the third panelist.
Yeah. Thank you very much. Dr. Emmanuel Agogo was meant to be part of the panel, but unfortunately he is on transit and airborne currently, so we're not able to have him, but be rest assured that the rest of the panelists will be able to discuss the particular topic he was meant to take. So we will go quickly into the panel discussion, and I will invite Professor Johanna Henfield to give us her first intervention by addressing this question: what are the biggest barriers to trust and transparency in cross-border communication during health emergencies, and how can these be overcome before a crisis occurs? Dr. Henfield.
Yeah, thank you, Chinwe. I'm just going to start off by saying that was a fantastic presentation by Esther. I hope you can hear me okay. I'm on a bit of a shoestring connection, and really to thank everybody for the invitation. So I'm just going to very quickly say we are very proud to be close partners of EMPHNET. So it's nice to be at a joint EMPHNET IANPHI Secretariat. We are proud to be obviously a member of IANPHI and be hosting the IANPHI Secretariat since the beginning of this year. And Chinwe, we are proud to partner with Nigeria CDC. So I feel this is wonderful. Thank you for the invitation to be here amongst friends to discuss this important topic. So you mentioned what are the barriers to trust and communication. So the first, so I'm going to name 4, and then I'll try and spend a bit of time talking about what needs to be done or what can help to overcome these. So the first one is really the lack of clear information being available. So I think having clear standards that can be shared between countries, so common standards, are an essential part of having that information available. So that's why something like the IHR and the standards that the WHO set or regional organizations set are so important, because they provide a basis on which we can build trust, because we have a common standard that we've agreed to before. The second is not just having the information, having a clear standard and the information available in a form that can be shared, but having the lack of connection or the lack of channels of communication, right? So I think if you don't have clear common connection points or clear communication at regional level or cross-border with your neighbor, then it becomes hard to do that. So those first 2, I think, are probably sort of very much in the domain of what the IHR established, what regional bodies establish, some of the work that Esther's responsible for, some of the work that national bodies are responsible for. And then I think it gets a little bit more difficult. So I think the third barrier is a threat of negative consequences. Right, so countries may still fear, and may, for good reason or bad reason, or may fear negative consequences, and that's why trust becomes so important. But I just want to, in terms of the barriers, I think we have to be aware that the threat of negative consequences may also be a cause. And the fourth point I did want to mention is politics. It's maybe something completely unrelated, right? So there may be a reason that between two countries that are next to each other, they don't share information, and they don't want to share information. It's got nothing to do with public health. But if you plan for this in the preparedness, you do need to be prepared for that. And I think that's the point when a neutral intermediary is very important, and that's why the IHR or the WHO, for example, is so important, because it's this neutral intermediary. It's not just cross-border. So if we've got these 4 potential barriers to trust and information sharing, or the kind of trust that we have, how can we then overcome this? And so I think the first point is to build trust, you need time, right? So you do need to do this in the longer term. Everybody knows sort of trust arrives on a turtle and leaves on a horseback, right? So you do need to do this over time. And you do this by building relationships, but building relationships in a structured way between institutions. And I was thinking of one of the ways which have been successful both in the region that the RKI sits, but I was thinking this particularly because this is co-organized by EMPHNET. And those are the regional training programs that are done, for example, for the field epidemiologists. So these networks, professional networks where people have trained together across countries, but within a region, become incredibly powerful, right? And I think the FETP programs really have borne that out, and where they exist around laboratories, that's another point. I think then you can have things like joint activities such as joint simulation exercises across borders, and I know that this is good practice, and in many regions this is indeed implemented and taken forward. And then as a third point, I think in some regions you have regionally or cross-border implemented disease surveillance programs. And you, for example, in Europe, we have the European Centers for Disease Control. So we have a sharing mechanism there, the African Centers for Disease Control. And the regional CDCs play a really big role now, I think, in creating this, even though they may not be all as far. So if you have a very established system, you can have a very strongly integrated disease surveillance across borders. And where you don't have that, and that's why I wanted to come back to IANPHI, obviously the more informal networks between peers is important. So IANPHI as an association, for example, allows national public health institutes to find fora, for example, through this working group, that build trust over time. So in addition to the more structured programs, like I said, simulation exercises, professional training programs, integrated disease surveillance programs, also this peer-to-peer learning, I think, is essential. There are 2 points, and I'll finish with that. But there are 2 things I think that are really important to always bear in mind. Is if you don't have national system in place, then you're not going to have that good information to share, right? So we do need the surveillance systems to work at all countries. And the second point is that all these activities require some funding. So you do need financing for the national system, and you do need some level of financing for the exchange of trusted information. And I think those are the positive elements, because you need all of that in place, because as we know, if you don't, then we will be talking a bit about distrust and disinformation and the spread of that. It becomes very hard to counter that. But I'll leave it at that for now, Chinwe. Back to you.
Thank you very much, Joanna, for this highly insightful points. And I think definitely we'll come back also to some of these points later on for further more diving and discussion. So allow me now to go to the Dr. Mosef, asking him about the misinformation. We have seen how misinformation can cross borders very quickly, like a virus. How can neighboring countries coordinate their messaging to reduce confusion and maintain public trust? And I think there is too many lessons learned during the COVID-19 pandemic. So can you elaborate more in this point, and how can we build system for this misinformation and better coordination between neighboring countries?
Thank you. Thank you so much, Dr. Majid. So allow me just to start by emphasizing that as you rightly said, in our increasingly interconnected world, health emergencies not only bring pathogens or biological hazards, but also infodemic. Infodemic, as it is defined by WHO, is the overabundance of information, including false or misleading content circulating in digital and physical environment. So outbreaks are not just biological; they are also informational. And in this regard, I'd like to start by differentiating, as you said, you alluded to misinformation and disinformation. The difference between the two concepts, the misinformation, it comes to false or misleading content. It's not intentional, without harmful intent. So, but still, it's misleading, it's false. While this information, it's done intentionally. So it's spread. So the content is spread with intention to deceive or to secure maybe economic, political gains or causing public harm. So that's the difference between the two concepts, the two terms. So during the outbreak, the COVID-19 outbreaks, we witnessed, all of us, information hazards can hamper or be detrimental to the public health responses, undermining trust, delaying protective actions, and exacerbating risks. But before delving into the subjects, what is the regulatory or the legal framework governing this cross-border collaboration and coordinating risk communication and managing misinformation between countries? As my colleagues have so elegantly alluded to, there is the IHR, legally binding instrument to early detect, notify, and respond. Primarily the IHR Article 21, which stipulates very clearly that neighboring countries may enter into agreements in terms of joint surveillance and response. The IHR Article 44 about collaboration, assistance, and financing. The IHR Article 57, which encourage member states to conclude special treaties or arrangements in order to rapidly exchange public health information or to maybe jointly apply health measures. And also there is the pandemic agreement recently adopted by the member states, especially the Article 4 of the pandemic agreement, which is about prevention and surveillance, so stipulating that member states shall take steps through international collaboration in either bilateral, regional, or multilateral settings. So your question was about the coordination mechanisms, the coordinating risk communication and managing misinformation. That's the body of the question. If we break down this question, we have first the coordinating mechanisms, how to manage informations, and what are, if I may say, the key enablers to have a successful coordination mechanisms and proper managing misinformation. So risk communication is defined by the WHO as the real-time exchange of information, advice, and opinions between experts of officials and people who face hazard or threats to their survival, health, or economic social well-being. End of quote. So when it comes to health emergencies, there are multiple actors at play or operating at national, subnational, governments, ministries, health emergency operation centers, community organizations, media, social media platforms, civil society, and so on. So without proper coordination, there is a risk of duplication. So many entities saying or repeating the same thing, and also the risk of having gaps. Maybe some communities are not reached And the risk communication and community engagement coordination guide highlights that poor coordination weakens reach, efficiency, inclusion, and collaboration. Coordination also ensures consistent messaging across actors so that communities receive coherent advice rather than contradictory signals. The useful approach is to establish a coordination platform, like, for example, establishing or creating a task force or multi-agency working group or another system. So the other part of the questions is about managing misinformation. So misinformation, as I previously indicated, it's false information shared without malicious intent and intentionally. And this information, which is of false information with intent to deceive. So both misinformation and disinformation are serious threats in health emergencies. So the WHO describes infodemic management as a systemic use of risk and evidence-based approaches to manage the infodemic and reduce its impact on health behaviors during emergencies. What are the possible key actions? The key actions might include social listening. It means monitoring what people are seeing in the media, in the internet, the rumors, the newspapers, and so on. Also, the timely and transparent communication of what is known at what is unknown. So it's about transparency. It's about acknowledging uncertainty to build credibility. If we don't know something, we have to be transparent and acknowledge and recognize vis-a-vis the population that there is uncertainty surrounding a specific issue or topic. Also, working with digital platforms, WHO has collaborated with over 50 digital companies to help ensure science-based content. Also, to provide clear guidance to the public on how to evaluate informations. So coordination, it's crucial because misinformation management doesn't sit siloed. It's not in silo. So we have to break the silos and create channels of risk communication, community engagement, and digital communication. When the coordination is weak, misinformation responses can be fragmented, delayed, or inconsistent. So at the end of the day, inefficient. So the third part of the answer is the key enablers for success. So to succeed, we have to provide or to put in place enablers. The first one is the trust. Trust is the foundation of effective risk communication. So if communities don't trust the messenger, accordingly, messages may be ignored or rejected by the communities. Also, we have to listen to the community concerns. So coordination mechanism must include structures to capture community feedback, perception, rumors, questions, that enables the message to be tailored according to the specificities of the community. And of course, to have intervention efficient. Messages must be understandable, so available in local languages, sensitive to cultural norms, accessible across different media, offline as well as online for population with limited connectivity. Also, member states have to invest ahead of time in establishing coordination platforms, training communication staff, building partnerships with media, tech platforms, and testing systems via, for example, simulation exercises. Also, there is a need to establish monitoring information systems, so to track misinformation incidents, to measure reach and engagement, to adjust tactics accordingly. And finally, in sum, so preparedness remains the antidote to chaos. So countries should integrate infodemic management into their public health emergency plan. So train those spokespersons in charge of carrying the messages and rehearse through simulation exercises. So coordinating risk communication and managing misinformation are interdependent pillars for an effective emergency response. So coordination frameworks ensure that information is delivered in timely, consistent, and trusted manner. Managing information ensures that the information environment remains as clear and reliable as possible, therefore reinforcing protective behaviors and public trust. As we continue to confront global health threats from pandemics to emerging crises, investing in joint coordination mechanisms, building community-centered channels, harnessing digital tools, and committing to transparency and listening will not be optional. It's not a good idea. It's crucial and essential and vital. Thank you. Over to you, Mr. Chair.
Thank you so much, Professor Musi, for that very sound intervention on the role of infodemics and misinformation. I think the recurring theme that we've been hearing from all the speakers has been the importance of cross-border coordination and the role of trust in enhancing that. Professor Henfield mentioned the need to be mindful of what we are communicating and even the channel of communication, which you have also highlighted. Professor Dr. Hamblin, you spoke about the standard mechanisms for data sharing and also mentioned the IHR and the other global standards that are there to help coordinate information sharing across countries. But we also know that countries have their own surveillance systems and their different reporting protocols. So thank you for joining the panel, even after presenting your keynote speech. We're wondering what could be some of the challenges with data sharing across countries that have different standards and different protocols, and what lessons have we learned on how to make it easier to harmonize data across regions?
Thank you very much, Dr. Chinua. Yeah, excellent questions. And you're absolutely right. Most countries do have their own surveillance systems for very good reasons. They're tailored to their individual public health structures and their data protection laws and their resources, whether they're financial or, importantly, their human resource availability. And this brings strengths in itself to have that local adaptability. But then when we come to regional and global data sharing and harmonization, that's when we can face challenges. So you asked about the challenges. Some of these can come from the technical side of things. We can have different data formats and different standards, and that can be different data formats just in terms of whether it's being collected in a spreadsheet, in a database, how we send those, whether we send them by email or through an online platform. But also we can call things, we can be as simple as that we can call things differently. One country may call something Ebola, another country may say Ebola virus disease. And just those inconsistencies may then mean that we can't match the data very well. And again, we can have different definitions. A country's definition for a suspected case may be another country's probable case of Ebola. And we have seen that over the past few years. But then we also see, I think importantly, is that lack of interoperability between the national systems and often a regional system or an international system. So that's sort of on the technological side of things. But it's more than that. We also see legal barriers and policy barriers. We see data privacy concerns. I think it was mentioned, somebody mentioned in the chat about the concerns around national laws and sharing of information. And I think often that comes from people not actually being clear what they're allowed to share and what they're not allowed to share, rather than it breaking any laws. But then we have things like GDPR in the EU, which has changed how we can collect and store information. And often there are political sensitivities. People may, or governments may hesitate to share information quickly because they really do want to avoid the impacts that is seen in terms of the impact on travel or trade measures that can be applied very quickly from other countries and have serious implications. And then there's the other side of things. People are concerned about where that data is going. The trust, we keep coming back to this word of trust, but the trust that the people that you are sending your data to is, we are able to trust them, and that data will be stored securely. And then the ethical concerns around that as well. Often we have seen in the past that some countries, particularly low-income countries, may share data, but they don't always benefit from technologies or analysis that may result from it. So there are a lot of reasons why, and the challenges around having different surveillance systems. But we also have learned a number of lessons along the way. And I think some of these we have touched upon in terms of the need to have global standards. Dr. Johanna mentioned about common standards, and again, the time it takes to build the trust for people to actually be following those common standards. But we really do need to have these common standards early, so that people, when we're building new systems, we're aligning to them, so that our metadata behind it does align as well. We also think about how well some regional data platforms have worked. So we have ECDC, some of ECDC's initiatives have worked really well in terms of early warning. They have a EWRS, their early warning and response system for sharing information. So we can learn from that. And in fact, we are at WHO learning from that platform that they have and looking at modernizing some of the systems that we use for IHR reporting. So we want to learn from different regional initiatives that have worked well. There's also other regional data platforms, Africa CDC's data integration platforms. We see the IDSR system, the Integrated Disease Surveillance and Response System in the African region, really does work well in terms of sharing information about suspected cases of diseases with potential public health impacts. And we've also seen we've also learned the lessons from the importance of investing in capacity and in the infrastructure that goes alongside that. And we've really learned that data sharing requires both the software and the skills. So the workforce training in data science and informatics in health information systems, which we're sometimes quite poor at within the public health sphere, are really key to the work that we all do. It's not just the clinical, the epidemiological, but it's really, we need to train the workforce in data science, informatics, and health information systems. I think it's also really important that we promote examples of what's worked well. We saw during the COVID-19 pandemic. The platform called GizAid really allowed rapid genomic sharing, and this worked incredibly well and was really seen as a positive data and information sharing system during that pandemic. And we really need to encourage other models around data sharing for other information that relates to our surveillance data. So information, environmental information, information on animal health, clinical information, etc. And I think lastly, I'll just touch briefly upon the real need that we have now to use technology to bridge some of these gaps. So we all are beginning, I think, to utilize different AI tools, but we're probably behind the curve. Some people are definitely better at this than others. I'm not particularly great myself, but we really need to look at AI and use it to automate some of the mapping that we have between the local surveillance data and the needs of regional bodies. And we need to look at how APIs can be used more effectively to harmonize and bridge that gap. So I think there is legitimate reasons why different countries have different surveillance systems, and I think we really need to look at how we can use modern data science and different AI technologies to really harmonize the data between countries so that we can inform preparedness activities and response to outbreaks.
Thank you very much, Dr. Esther, for this very important point that you raised, and also mentioning examples from different parts of the world and from different regions. And also, you mentioned the integrated disease surveillance, and I think it is an important point also to look for in-country coordination also before also going to the regional level. So we need to consolidate coordination and collaboration within the country before going to the regional level. And I think this is in line with what Prof. Joanna mentioned about the building the national systems and its importance before going to the cross-border. Back to you, Dr. Joanna, for the point that you raised, and I thank you very much for mentioning the importance of politics. And I think this is a key area so it is not purely a technical issue, it's beyond technical issues, the relationship between countries and how this play a very important role in building trust between countries and smoothing the process. So the question is, what legal or policy changes at the national or regional levels would make it easier to and more efficient to share timely, actionable information during the early stages of pandemic?
Yeah, thank you. I think so many important points have been mentioned. So I think I'm just going to mention a couple of things. So I think, first of all, you need to build the national system while you build the cross-border. I don't think we've got time to build one perfect and then build the next. So I think we do have to do we do have to do it at the same time. I think the policy and legal regulation that you need to enable data sharing in your context will vary from region to region. And I think one of the reasons why regional collaboration has become so important is because we have this global system like the IHR. And then, of course, there's an immediate regional geographic dimension to an outbreak in many cases. We also know from the map that we saw from Esther that obviously there's the global dimension immediately, but there's also a regional dimension to that sharing. And often within regions and regional governance, there are specificities. So it's hard to say what system there's not one system that fits all, but I think it's important for regions to work together, and that's where the regional CDCs have this strong role, because they can work out within a region how countries can share this data effectively. I wanted to also stress, just underline the point of the value of having national surveillance systems. I think you ultimately, public health is also a science, so we learn from that, right? So people really looking at case definitions, really trying to understand what the differences are, they make all of our EPI practices better. So I would strongly encourage that. But then you need that common language to be able to communicate. And that's what these common standards in public health intelligence or common standards in disease reporting give us. And that's why they're important. So I think work out what's the regional legal and policy framework that you can work through. I think regional CDCs have a core role to play. I think global coordination is important because we learn from the best practices. And of course, it all sort of depends on the strong national. So unfortunately, we have to work at all those levels, but they each have a unique function. Thank you.
Yeah, thank you very much, Professor Johanna, for that very, very timely response. So we will just have an icebreaker and take the poll. Let's see what participants can share with us from their experience. We'll be presenting a case scenario, and we would require that you just answer the questions as honestly as you can. And then we'll get the panelists to respond to the popular poll. So you must have noticed something pop up, but I will read the case scenario for you. There is a new influenza-like illness which has been detected in one country in the region, in your region, and early evidence suggests potential human-to-human transmission. Neighbors are concerned about spread, but they are hesitant to share case details due to political and economic sensitivities. So please address the quickly 3 questions that you can see pop up on your screen. We'll give just 1 minute for that. Tech team, please tell us when you're ready, and then you project the responses, the chat, and then we will invite the panelists, maybe 2 panelists to react. While this is going on, just a reminder that you can post your questions in the Q&A box. We already have a couple, and we will try as much as possible as time permits to address them. So let's have the results now, please. Okay, so the first one I can see the popular response is on case count. It says, what is the most immediate information that should be shared with neighboring countries? So the popular response there is case counts, followed by suspected origin and containment measures are equal. And then for the second one, who should lead the communication of this information? A lot of you said national government, while more than a quarter said regional organizations. And then finally, what channels would you prioritize for communicating with neighboring countries? Most people said WHO IHR notification, interestingly, and then 16% direct technical team calls. So let's have the panelists. You can respond, just react to any of these responses that you think you would like to respond to. Would you like, anyone can respond, just unmute and speak. Professor, yes, Henfield, I can see you're smiling. Please go ahead.
Yeah, I'm smiling about the case count. I mean, yes, you want the case count, but you also want to know the characterization, right? How does it present? Because you've only influenza-like. Okay, so you want the case count. Yeah, as much as possible information about transmission, right? About suspected patterns of transmission. That's what you want, because you want to. Yeah. So sorry, that's just my gut reaction. I think it's right with something as human to human transmission influenza. Like I also think IHR probably the global, because it's so immediately of concern to everybody, right? So that's why people will have opted. That would be my reaction to seeing that most people opted for the IHR focal point, because this is of course something where I say like, whoa, WHO needs to know straight away. But yeah, interesting. Okay.
Absolutely. Thank you
Yeah.
for that response. Yeah,
If I
I
may,
agree that it's a bit simplistic, the question, but it's good that we're getting this feedback. Yeah, Professor Musif.
yes, thank you. So basically, under the IHR requirements, as it has been mentioned during the different presentations, so member states are, especially when it comes to neighboring countries, are encouraging to establish joint agreements that support cross-border collaboration. So under harmonized public health surveillance and control measures, under establishing cross-border communication coordination protocols or mechanism to enable timely information, and under coordinating available resources to maximize the efficiency of the response. So member states should share all any available information first through the as it has mentioned during the presentation to the EIS, Event Information System, by the national HR focal point to the WHO regional office, and then between member states. So the more information is shared, the better. And it helps to create an environment of transparency, and enables member states to go forward. And it enables also to avoid some very negative reactions from the member states. So it's better. So member states should not leave the vacuum. The vacuum should always to be filled. And allow me to remind you of what event about one event I just remembered that occurred during the peak of the COVID-19. So one medical doctor working in a lab in Tanzania, in African region, sent a sample of a PCR to a colleague in South Africa, just to ensure to have the results of the genomic sequencing. And that's how the Omicron variant was discovered in South Africa. And guess what? On the same day, on the same very day, more than 50 countries suspended flights to and from South Africa. So the better we spread information, the more we spread information, the more we are clear and transparent, the lesser we can have negative reactions from member states, like this example of unjustified travel restrictions. Over to you, Chair.
Thank you very much, Dr. Mustaf. So, Tuni, I think we have a lot of questions on the Q&A, so we can pick a few of them. And I see here maybe two interrelated questions from Dr. Muhammad, the EMPHNET Executive Director, and I think this is also very important to highlight. How can we move from ad hoc data sharing during crises or emergencies to a structured, institutionalized regional framework for health information exchange? So that's toward more building the system. Also, the second question, which is I see it interrelated, how can we also balance national data ownership with the regional and global responsibilities to share critical health information, particularly during cross-border outbreaks? So maybe we can start with Dr. Easter from WHO.
Sorry, I was on mute. Yes, great problem. Great problem to have, balancing national data ownership with regional needs and global needs. As we said earlier, there's a complete countries need to have the control over the data that they've collected within their borders. It's countries own their own data, and that needs to be respected. But as we know, that information needs to be shared so that other countries can take their preparedness actions to stop the particular pathogen crossing borders. So I think it's really about a balance between what's essential to be shared and what's not so essential to be shared. And I think it goes back to that trust that we were talking about, sort of building the trust in relative peacetime, and so people feel more comfortable sharing the information to regional and global bodies. And I think if during that peacetime we take the time to really look at how data can be shared, and look at the regional data hubs and how they work for countries themselves, so that countries feel comfortable before an event about where their information is going and how it will be used. So I think doing that work before we move into sort of an outbreak which has the potential to cross borders is really important. And then I think we also need to think about acknowledging and making sure that the people who share the information, as well as benefit from anything that the information is useful, they're also acknowledged that where the information has come from. So I think for me, it's a real balance between a country having ownership of their data with the regional needs and with the global needs. So I think people need to be involved in designing systems that they feel comfortable with before we get to an event.
Yeah, thank you so much. I think the next question I want to ask is related to what you just said, and that was posted by Khalil, Hanan Khalil. It says, would not informal networks be breaking national laws for sharing information between countries? So it's acknowledging that there are informal networks that could break national laws for sharing information between countries and what this implies for cross-border collaboration. Professor Henfield, would you like to respond to that?
Yeah, I'm happy to, Jinwei. I think it's an important point to say. I mean, the informal networks are not designed to replace anything formal, right? It's about how do you generate the trust to make a formal governance structure work? That Dr. Mohanad was asking, how can we have a regional formalized institutional governance structure? And you need to build that, but then that's not going to work unless you've got the trust within that system that people actually share. So the importance, that's where this importance of generating, in a way, connections between public health professionals across borders within a region, for example, training programs. I mentioned regional training programs. I mentioned earlier that both EMPHNET and, for example, in the European region have been very successful, and Africa CDC's got its own, so regions are doing. And I think it's by all means not to suggest that people do things that are illegal. I think it's about generating the trust at the same time as doing the institution building, and recognizing that especially cross-border and very rapid sharing of signals, in a way you fire on all cylinders. But I didn't mean to create the impression of something undue. It's about how do you then get the systems you're building to actually work. And for that, you need the trust. And for that, you need something more than just something written down. Thank you.
Thank you.
Thank you very much for this very fruitful webinar, and for all your input. And definitely the topic cannot be covered in one session. And definitely we should think about next steps and future maybe sessions for further more in-depth discussion, and also to respond to many questions and points that needs further more clarification and elaboration. I see the hand of Dr. Musef, if you would like to add something.
Yes.
before the conclusion.
So thank you, Mr. Chair. Just about this question, the question, how can we balance national data ownership with the regional and global responsibilities. This particular question drew my attention because I do believe that there are principles that should be agreed upon between countries. First, the principle of sovereignty and stewardship. Let's remember that the IHR, the Article 3, is about the sovereignty. So countries own their data. They also act as stewards, and when data affects others' health security. So there is a principle which it's called traffic light sharing model. So when it comes to security sensitive data, for example, there can be the system of traffic lights. And also there is also the interoperability. Building bridges and use time-boxed workflow of cross-border signals, and also determine what to share early. So what is define low-risk related data and high-value data. For example, syndromic signals like counts, trains, but no identities. Agree on case definition, on testing criteria, points of interest, screening status, and so on. That's a small contribution. Thank you. Over to you, Chair.
Chinwe, so I think we reached the end of this webinar. Thank you again for all of you for your participation, for your insight. And as I said, that definitely we will have a second round of furthermore in the future discussion. It is a key area and how we can build our systems. And I think from our webinar, we have too many key takeaways that we could think about it. So it's clearly that we need to build a more stronger collaboration, and it is very essential. And this should be at different levels. So we should think about this at the global, regional level, as well as also coordinated mechanism at the country level. So I think it's the importance and highlighting how can we work together on promoting for more transparency, accountability, equity, and information sharing in a more structured, formulated way, and not only related to emergencies or ad hoc basis, but on a long run and also in a more structured system. It is very important that to highlight the importance of integration and different initiatives to bring different pieces together in strengthening surveillance systems, in taking into consideration the compatibility and also the interoperability of different systems at the country level, so that could ease also the data or the information sharing between countries and exchange of information. Definitely, we cannot avoid issues like politics and relationships and the overall context of countries and its impact on the development of these platforms or collaborative mechanisms. I think very importantly that we need to build the structured relationship between countries and how this could affect also the information sharing, and also how can we think about the professional networks. And I think have been mentioned like the FATB, we are as an EMPHNET as one of these networks. So how can we utilize these networks? IANPHI also as an association, how can we use different moves, different ways in establishing systems and in promoting for a more structured and data and or information sharing between different countries. Lastly, I think the issue of building the national systems as a key block for all the next steps. So that's just few ideas. I try to take it from different points during the discussion. I don't know if Dr. Chinwe would like to add anything to this before the closing? We still have 1 minute.
No, I think you've done a very excellent job. Thank you so much for summarizing it so well. And just to say that we intend to have a communique that comes out of this webinar, which we made publicly available. And we are hoping that if we have the opportunity, we'll be able to present it at the pre-conference meeting of the Conference of Public Health in Africa. So we look forward to engaging with the participants in future webinars, and thanks to our keynote speaker and the excellent panelists. Thank you so much for your time and for the wonderful and rich discussions we've had. Looking forward to more collaborations across borders that will help us to prevent and respond very quickly to the next pandemic. Thank you, everyone, and have a very great and wonderful rest of your day.
Thank you, Amor.
Thank you all.
Thank you.
Thank
Bye.
you. Bye-bye.
Bye.